Well, thank you very much. It's exciting to be back in front of people and try to help folks with myeloma, both here in person and virtually for those of you that are online. And as you heard, I'm Dr. Elizabeth Manasank for today, so I will try to pitch in for her, although I don't have quite the right accent, nor will I give it with the same level of verve that she has. But we did want to start off this session by talking about smoldering multiple myeloma, or what we generally call precursor diseases. Many of you either have myeloma or have a loved one who has myeloma and has gotten treatment for it. Almost all of those patients at some point before they were diagnosed with symptomatic myeloma had an earlier phase of the disease. And the two that we mostly define are either something called MGUS, which stands for monoclonal gammopathy of undetermined significance. Essentially, what that means is that you have an abnormal protein on this test called the serum protein electrophoresis and immunofixation, but the level is low enough that it's not causing your body any problems. And then a slightly more advanced state of that is called smoldering multiple myeloma, where typically the protein is a little bit higher. The number of abnormal myeloma cells in the bone marrow is a little bit greater, but still there is no evidence of what we call end organ damage, which means, for example, that you don't have high calcium levels, or you don't have an elevated creatinine, which means decreased kidney function. You don't have significant anemia, and you don't have any bone damage that we can ascribe to the multiple myeloma itself. Now, for many years in this smoldering and MGUS space, the standard of care has been essentially watch and wait. And that can be, I'm sure, from a patient perspective, very frustrating, because the worst thing after you're told that you have a cancer, because smoldering myeloma is considered a cancer. MGUS is probably a benign precursor, but probably the most frustrating thing if you have smoldering myeloma is to know that you have a cancer and your cancer doctor says, we're not really going to do anything about it. We're just going to watch and wait. And you're thinking, why don't we do something? I want this thing out of my body. In the past, the reason that we did that, there were a couple of them. First of all, not everybody with one of these precursors actually progresses. If you have MGUS, the average risk of progression is about 1% per year. So you can imagine if you wanted to treat people, that means that if you had an effective treatment that would prevent the disease from progressing, you would be treating 100 people, but 99 of them weren't going to progress anyway, and only one of them was going to. So that would be pretty expensive, and all of these drugs have some side effects. So you would be exposing a lot of people to risk with only a couple people benefiting. Now, for smoldering myeloma, depending on where you are on the spectrum, the risk is a little bit higher. It's about 10% on average per year for the first 5 years. So that gets to a slightly higher risk, but we still see that many people with smoldering disease don't progress. So one reason there hasn't been treatment is because of that. The second reason is that, at least in the past, with the therapies that were available, studies were done looking at whether earlier treatment helped patients live longer. And it turned out that the therapies that were available did reduce the amount of myeloma, but the survival of patients wasn't any longer. And so why take chemotherapy if you're going to have side effects and you're not going to live any longer? So one of the things that we're doing here at MD Anderson, and this is a collaborative effort with many other academic centers, is to understand the biology of MGUS and smoldering myeloma better. What I mean by that is right now, the way that we determine your risk of progression is based on clinical criteria. So those are things like how much myeloma protein do you have in your blood? What is the result for a related test called the serum free light chain assay? And how many myeloma cells do you have in your bone marrow? And based on that, we can put you in a low, intermediate, or high risk of progression. But even in the high risk group, there are still patients who do not progress. So we're doing a lot of molecular and immunology studies trying to understand the myeloma cell itself, as well as all of the cells around it in the bone marrow. Those are important because it turns out the myeloma cell is actually pretty fragile. For example, if one of you gets a bone marrow and you contribute a part of it to research and we get it in our lab, if we put the myeloma cells in a dish and feed them really good stuff, like, you give them filet mignon or something like that, they still only survive 2, 3, or 4 days at the most, and then they die off. The reason for that is that they really rely on the cells around them in the bone marrow. That's called the tumor microenvironment for support. So to understand the biology, you have to look at not just what's wrong in the myeloma cell itself, but how it changes the bone marrow to allow it to survive. And Dr. Manasank here at MD Anderson is leading that effort. Part of it is to do what's called single cell profiling, which means that we can, from a bone marrow, look at each individual myeloma cell and do sequencing or gene expression looking at 40,000 genes in each individual myeloma cell, as well as in all of the immune cells. And what we're trying to do is better predict, based on the characteristics of the myeloma and of the immune response in the bone marrow, who will progress and who will not. Because we are now developing some effective therapies that are better than the drugs that we tried before, but still we want to give them to those patients who are going to progress, whereas for those patients who we would predict would not, we'd rather, of course, spare them the inconvenience and the risk of side effects, and of course, from a societal perspective, the cost of therapy. We do have some early hints about changes in the immune system that may help myeloma to progress. One example that I'll give you are a type of cell called macrophages. Macrophages are an immune cell type whose job really is to eat up abnormal cells. That can include bacteria, or in this case, cancer cells. And we have a number of lines of evidence from the studies that macrophages are suppressed in smoldering myeloma. And that makes sense because if you're a myeloma cell and you're trying to survive and the patient's immune system is attacking you, what you want to do is inhibit some of those cells so that you can make it through the day. And macrophages are one of the cell types that seem to be inhibited. This also, by the way, is not just a theoretical exercise, but we now have drugs that are being tried in other diseases, which are essentially what are called checkpoint inhibitors. And what they do is they can activate certain types of immune cells. So right now we're running studies in mice, which actually are a very good model for smoldering myeloma. And we're using antibodies that activate macrophages to see if they will prevent progression in these mice. And if they do, we have comparable antibodies that we can then try in patients with smoldering myeloma. And the nice thing about that is that some of the current therapies that are being tried in smoldering disease include things like lenalidomide or lenalidomide and dexamethasone. These are the same things that we've used in active myeloma, and they don't cure active myeloma. So there's really no reason to think that they will do better in the smoldering space, not to mention that they do have some side effects, whereas these immune therapies are very targeted. And we hope, therefore, to be able to do better in terms of less toxicity and greater efficacy. And the other thing, which I think is a theme for the meeting today, is how to try to personalize this. There are probably multiple pathways through which myeloma can progress. And Mr. Smith versus Mrs. Jones, their myeloma cells may have different pathways that they take. And through this very detailed molecular profiling, we think that we're going to be able to predict which pathway each patient will take. And therefore, we will hopefully be able to block that pathway and not really futz with any of the others. So that's hopefully going to be in the future a very individualized therapy. The other approach that we're taking, and this is a trial that's currently ongoing, is with a vaccine study. And of course, we all know a lot about vaccines these days, given COVID. Maybe we know a little bit more than we wanted to know. But we're also taking the same approach with myeloma. The normal version of a myeloma cell is something called a plasma cell. In order for a normal plasma into a myeloma cell, mutations. Otherwise, it would stay a normal plasma cell. And what we're doing is we take the bone marrow from patients on this trial. We sequence the DNA and the RNA so that we know what genes are mutated. And then we can predict which of those mutations will raise a good immune response. Then we make a cocktail of 10 peptides which represent those mutations. So it's kind of like the flu vaccine, where you get a short protein which helps you build immunity against flu proteins. This is the same concept. We're building immunity against abnormal proteins that are only present in the myeloma cell. So there's really two nice things here. So first of all, this is a personalized vaccine because every patient will have slightly different mutations. And again, Mr. Smith versus Mrs. Jones will therefore get vaccines. The other thing that's really nice about it is that these are mutations that are only present in the myeloma cells and not in your normal cells. And so unlike some of the drug therapies that we use, which can impact both, a vaccine has the potential to only impact on the myeloma cells and not the normal cells. So we're finishing up this trial, and then we'll analyze it to see if elicited responses, if we've essentially strengthened the immune system against the myeloma cells, number one. And number two, we're going to look at whether that delays the time to progression to active myeloma. And maybe in the best case scenario, we'll even find that progression is halted, which would be really great. And then this approach can be taken on a more national level. I think those are some of the highlights that I would probably want to hit for the smoldering space. It is important for people to know about this because, in part, patients have family members, of course, and first-degree relatives, depending on the study, have about a 2 to a 4-fold increased risk of having myeloma or a related condition. There is not yet a recommendation for routine screening of family members, but definitely other members of the family should know that you have this diagnosis. And therefore, if they ever go to the doctor with a problem and mention this, it may have the doctor think about MGUS or smoldering myeloma And one of the good things about being diagnosed earlier is that we think that we can do better treating people before the disease becomes active. And with some of these immune therapy approaches, we hope to be able to kind of nip it in the bud and prevent it from getting to the point where you've got all these serious complications, including bone disease, renal failure, et cetera. So we are excited about this space because we think there is a great potential to cure. And the earlier we're able to pick people up with this disease, the better. I think I'll conclude there, and I'm happy to take any questions either now or later. Later, fair enough. So write them down if you want to. I know I wouldn't be able to remember a question later if I had one now, and we'll be able to answer them at that point.